and make those embers glow. I'm on my way, and I don't skip a beat. I can't help it, I've got happy feet. So good, I do what I want and it's understood. There's no stopping me when I'm doing my thing. I'm doing my thing. I'ma do me. You know what I mean. I'm on fire. I'm feeling glad there's a spark in my soul. Feel my heart goes in. I'm clapping my hands and I'm pulling these strings. No stopping me when I'm doing my thing. I'm doing my thing. I'ma do me. I'ma do me. You know what I mean. You know what I mean. I'm on fire. Yes, I am. I'ma do me. I'ma do me. You know what I mean. You know what I mean. I'm on
I'm steady walking like I got 3 commas in my bank account, living loud. So get your cameras out. I'll probably do the same thing if I was you. Looking at me now, now. Put up your lights and keep them flashing. Don't ever put them down, down, down. Look at me now. Look at me now. Look at me now. Good God, I'm looking sweet. Right now I'm feeling like a slice of heaven, and you wanna sink your teeth to me. And the way that I move my feet, it's like I got this whole world spinning round to the rhythm of my heartbeat. Put up your lights and keep them flashing. Don't ever put them down, down, down. Look at me now. Look at me now. Look at me now. Look at me now. I feel so good. I feel so money. I feel so good. I feel so money. Look at me now. Look at me now. Look at me now. Look at me now. I feel so good. I feel so money. Look at me now. So good. I feel so money. Look
I can't seem to focus, and you don't seem to notice I'm not here. I'm just a mirror. You check your complexion to find your reflections all alone. I had to go. Can't you hear me? I'm not coming home. Do you understand? I've changed my plans, 'cause I'm in love with my future. Can't wait to meet her. And I'm in love, but not with anybody else. Just wanna get to know myself. I know supposedly I'm lonely now. No, I'm supposed to be unhappy without someone, but aren't I someone? You're so handsome, but I know better than to drive you home. 'Cause you'd invite me in, and I'd be yours again. But I'm in love with my future, and you don't know her. And I'm in love, but not with anybody here. I'll see you in a couple years.
It's been a little while since I looked in your eyes and walked that bridge to the other side. Mama says it's gonna get cold in the night, but if I picture you, then I'll be alright. I am ready. I am ready for you to be here. It's been a little while since I held your hand, so my arms won't stretch to your distant lands. Give me every person in the whole wide world, and I'll pick you out in a second, girl. I am ready. I am ready for you to be here. For you.
Hello, everybody. This is Mark, your evening late night coffee show live host once again. Um, had a great weekend. Hope you guys are all well, all safe. Good to see you all. My favorite time of the weekend. My daughter's asleep. Everybody's happy, and tonight is a special night because tonight is personal. I'm going to do a private study club, and I'm just inviting you guys to join me. It's a little bit of a lengthy one today, so I'm going to shorten the prelude, and we're just gonna jump right on. So some of you guys have been to a previous reaction video. First of all, hello to everybody. Everybody. Can somebody give me a thumbs up if you guys can hear me okay? I just want to make sure my audio video is all good. Thumbs good? All good? Then I'm going to keep on talking. All right, excellent, okay? The usual suspect, Lisa, Anis. We have Badad, Tan Nguyen, and Hanwoo Choi joining from Arizona. Okay, great. From New York. We have Izzy. Hello, Izzy. How you doing? Okay. All right. We also have Sean joining all the way from Chicago. The guy just flies all around the world. Okay. Be safe, my friend, Sean. Okay. So tonight is a special evening. Once in a while, what I will do is basically choose a lecture or a live surgery video for my own sake, because I have to learn a few things as well, right? I don't always just lecture and teach other doctors, but I want to learn as well. And there's specific some lecturers that I really respect and I follow, and I really respect their philosophy. And they might do some surgery differently, might have a little bit of different perspective, and do things to a different way with a different philosophy, but that's all good because difference makes us good. I don't want to learn from somebody who does everything exactly the same way as I do because I don't learn anything, right? And my goal is to not only be a good teacher, but also myself to be a good student. So let's jump right in, guys, okay? All right, so tonight, I'm just gonna bring right here. Tonight, the main speaker is none other than Dr. Jeon In-Seong. Most of you guys probably never heard of him. That's because he's a bit new to Canada and also North America. He's very well known, of course, in South Korea. He's been one of the main global speaker for company Hyosun, also known as OSTEM. I personally got to know him about 5-6 years ago when we shared a podium together and had a chance to meet a few times. Incredible clinician, prolific surgeon. He does so many surgery, but he's an academic. He's a PhD, and he is one of the main speaker for Dental Bean, which is a online platform. Started with really well-known progressive clinicians in South Korea, and they gathered together and formed the online platform similar to Bice Institute, but their scale is a lot bigger. And one of my favorite speaker is Dr. Jeon, and also his friend Dr. Cho. We also did a late night coffee show with Dr. Cho as well, right? So tonight is Dr. Jeon, and if I were to add a little bit, was the video that I will be watching is it's not it's not a live show. It was recorded, and it was actually on live in April the 19th on Monday, but this was like I was too busy to watch it, so what I did was I got a chance to have a link to the video, and I had a permission to download it so that I can watch it on my own time with you guys. Okay, so thanks to Dental Bean for allowing me to do so. Now the video was a little bit long. It was like almost like 2 hours. Of course, we're not going to spend 2 hours tonight with you guys doing this. So there was a portion of his lecture. It's about an hour long, so tonight might be a little bit longer one. Not everybody will stay up that late, but that's okay. So I chose a section of a video that specifically talks about his concept and his way of dealing with a complication, right? Complication is a big topic, man. As you guys know, I post a lot of my complication, and I see in my own practice at least 4 to 5 complication cases referring to me every week, and the number is increasing, okay, more and more, because more general dentists to offer implant dentistry, which is good, but not every dentist know how to deal with complication, because complications come in many different form, right? So I look forward to watching this video with you. I haven't watched it either, so it's going to be new for you and me, so we'll have fun, okay? All right, so let's go to it, okay? I'm just going to push this down. How do I do this? All right, where was it? I loaded it. Here we go. Let's go to it. Let's go to the full screen, and let's enjoy this show. All right. Okay, as you guys know the rules of engagement, you are entitled to get a CE credit, AGD approved. You need to shout out your first name, last name, comma, and the city, and I will give you a verification code at the end of the session, okay? All right, so that's the rules of engagement. Once you receive the verification code, all you have to do is email info@bisonstitute.com, attention grace, and you will receive a certificate of attendance and a CE credit, okay? Yeah, and that's CE credit for any country. Hey Albert, my friend.
8, 7, 6, 5, 4, 3, 2, 1.
Hi everyone. My name is In-Seong Jeon from Korea. You can call me Dr. Jeon from now on. As previously announced, today my title is the complication pathway. The last time I talked about the full mouth rehabilitation very briefly. So today I already announced the today topic. I organized several hundred topics with the Dental Bin global webinar. So this is a very small beginning, I know, but will be a very large content. I sincerely hope. So this time is the 9 a.m. in the Korean local time. According to your location, maybe the time is different. Today is the April the 19th. So from now on, every
So this
month
was on
I will
April the
lecture by
19th.
the English. So today's topic is the understanding of the complication.
The good thing is
pathway.
that he's lecturing this in English, so most of us should be able to understand it.
Understanding first, and second of all, today I will talk about how to remove an implant. So very briefly, just there are too many techniques for implant remover. So initially I talk about the complication pathway, and secondarily I talk about the implant remover technique. We start the implant.
That's good. He's going to talk about his method of removing failing implants
the
tonight.
surgical aspect, and then next one is the prosthetic aspect. So there are too many complications we meet, from the numbness and intraoperative and then postoperative. So sometimes the sinus, bronch, GBL, and so on. And then the prosthetic complication, there are too many complications. Sometimes the prosthetic fracture, screw loosening, and contact loosening, and so on. And then middle part, just the peri-implant mucositis, focused on the soft tissue inflammation, and then peri-implantitis, focused on the bone inflammation. So actually this is the lecture content for the complication. But today I want to talk about pathway of the complication. The good surgeon know how to operate, and then the better surgeon know when to operate. And then great surgeon knows when not to operate. At the end of the presentation, I will talk about what is the greatest surgeon. So this is some of the level of the implantology.
Less is more,
So
right?
the
Less is more.
complication, there is the mixed situation. Sometimes the patient problem, the systemic disease or bone density. And then next one is the doctor problem, the surgical skill and prosthetic skills. And the final one is the company problem, the implant itself problem, sometimes the very thin wall, sometimes the contamination of the implant surface, and some problem of the topography of the implant surface. There are many regions combined for the complication. We have to keep in mind this one. If failure doesn't kill you, it surely be the driving force. Every implant failure has its own regions, definitely.
It's so true. I learned so much about implant dentistry by facing a lot of my own failures.
I suggest the time is the first factor. So, according to the time, we have to learn. We have to understand the complication pathway. Initially, the zero operation time. At this moment, we meet many complications. And the next time is the suture removal time. Maybe 1 or 2 weeks later, sometime 3 to 4 weeks later, you have to take out the silk. And then next one, 4 weeks later. This is a very important stage. 4 weeks means some of the infection occur, usually. And then next one is several months later, at the time of the second surgery, cover screw removal and helicam insertion. And then
That's
next
optional.
one is the prosthetic delivery time. You insert the abutment and then crown delivery. And next one, if you apply the cement retention, you have to check the 1 month later, definitely. This is the post-prosthetically period. And then several months later, 6 months, you have to check the several factors for the prosthetic structure. With this period repeatedly, you have to check until 3 years. 3 years means this is the functional rehabilitation completion period. So according to time, from the surgery, suture removal, 4 weeks later, second surgery, delivery, 1 month, 6 months, 3 years. With this sequence, every time we often definitely meet many complications. So
That's
in
a lot.
our knowledge,
That's
just
a
we
lot.
have to organize this kind of the
Let me ask you guys a question. How many of you guys have this much visit for a single tooth implant? There's no right or wrong, right? I think, Professor John, he is one of the perfectionists, right? This is the right thing to do. But to be honest with me, I don't do this many checks. Maybe I should, right? Maybe I should.
according to time. Let's check briefly one by one. Actually, I have a lecture content, the complication 3 days course. That means it requires 30 hours for the check the every complication. But today, briefly, as I mentioned earlier, I check the whole complication pathway first. At the time of the surgery, you meet several complications. I just call this is the intraoperative complication. Sometimes the bleeding. Next one, numbness, nerve damage. And then initial stability failure. Sometimes too high stability or sometimes too low stability. Of course, it is related with the bone density and then drilling sequence. This kind of the bleeding, sometimes they make some of the swelling usually. So at the time of the surgery, if you meet some of the bleeding, definitely require coagulation. Sometimes soft tissue bleeding, sometimes hard tissue bleeding. Of course, it requires another lecture content. I organized already several hundred topics with the Dental Being global webinar. So every month I will open one by one. Numbness is also very dangerous situation. So it requires many skills and then many concept techniques. And then initial stability. If you ask me, what is the most 3 factors for the whole implant treatment field? I know without hesitation I can say the first one is initial stability. Second one, suture technique. Final one, impression taking. So anyhow, this is our job. This is our mission. Bleeding control, nerve control, initial stability control. This is the intraoperative complication. And then sometime immediate correction or next day correction. And then initial stability failure means it requires immediate correction or delayed placement is better after socket preservation. There are too many things during the surgery. Next one is suture removal time. Suture removal. That means sometimes the healed ridge area, you can take out the silk usually 1 week later. But sometimes much GBL or soft tissue grafting area, sometimes suture removal 3 weeks later or 4 weeks later. At this time, we have to check GBL complication. Sometimes bone particle come out. Sometimes membrane some mobility. Membrane partial come out or full come out. This is the GBL complication. Please not confuse. This is not GBL failure. This is the GBL complication. At this time, if we apply some skill, this is not failure. Change it to the success. And then wound dehiscence. This wound dehiscence or GBL complication, usually big reason is improper flap management. That means
Soft tissue.
improper suture techniques. So
Soft
this is
tissue management
at
is
the time
so
of the suture
important, guys.
removal,
So
You
important.
meet this kind of the several complications. And then next one, 4 weeks later. 4 weeks means very significant because 4 weeks means some of the suppurative infection develop more and more, and then this is the some of the infection like this one. Sometimes heating necrosis, sometimes GBL infection. GBL infection or heating necrosis 1 or 2 weeks later is impossible. Usually 4 weeks later. That means you have to check the patient definitely 4 weeks later after surgery. So at this time, if you find some of the GBL infection, you have to insert the healing cap definitely because the healing cap is the auto drain function. And then heating necrosis.
So did you guys get that? Okay, some of you might not have got it because he's talking pretty fast here. So some of us, okay, well, all of us know that initial stability is important, right? And our goal is to get a proper initial stability so that we can put a healing abutment. And there's an advantage to place healing abutment because one of that is we can avoid secondary surgery uncovery, right? In my opinion, if you get good stability, you can have more complication if you put a cover screw and try to get a primary closure. Okay, it's better for me, in my opinion, to put a healing abutment. However, if there are situations, what he's saying is that you don't get a proper stability and you have a cover screw over and you put a soft tissue over, and if you check it in 4 weeks later, okay, and through that little hole, if it is draining, if there's a infection happening, the best way to correct that is remove the cover screw and put the healing abutment, even if, okay, the stability was not ideal. Sometimes you have to bite the bullet and take that up, put a healing abutment on it, and just be careful, have patient to not bite anything heavy, because that helps to auto drain. That's what he's talking about, okay?
Means usually combine severe pain. That means you have to change implant. So anyhow, this kind of the pathway, we have to understand this one. And the next one is second surgery. You take out the cover screw, you insert the healing cap. Sometimes at this time you find
He's saying he's
the
using
marginal bone
word healing
resorption.
cap, but what he means healing abutment.
Marginal bone resorption, there are too many regions. Usually the big region, first one, too high initial stability. And then sometimes GBL failure. According to the bone come out, the membrane mobility, that means the marginal bone slightly resorption. This is the second reason. And then next one is sometimes at the time of the impression taking, sometimes implant come out. That means fibrous encapsulation. Fibrous encapsulation, the big reason is some micromotion induce the implant some the mobility. That means implant healing by the soft tissue only, not bone area. So implant failure by fibrous encapsulation or GBL failure or marginal bone resorption, you can find at the time of the second surgery. And then final one, sometimes infection from the implant itself problem. That means also slightly pain combined. Of course, that means implant removal is okay. So there are some the according to time, there are complication pathway, we have to understand this one.
What I found, I used to get a lot of fibrous encapsulation with my earlier implant, like an endopore, which did not, it was a press fit implant. like those Cositech implants, all the Endoport implants, some of the earlier press-fit Zimmer implant, I used to experience a lot more fibrous encapsulation and early failure. Once I switched over to a screw type of implant, I start to see a far less fibrous encapsulation early failure. And when I switched over to an implant that was grade 4 titanium with a dual surface treatment, sandblast and SDS, such as a Straumann or Hyosin or Megagen type of implant, I rarely ever see fibrous encapsulation, even in those situations where I don't get good initial stability. So it's kind of interesting.
Next one is, this is the operation, suture remover. 4 weeks later, second surgery. This is the before prosthetic delivery. So GBL complication and wound dehiscence. GBL infection, heating necrosis. Marginal bone resorption, GBL failure. And implant failure by fibrous or infection problem. So I just call, this is the osseointegration failure. Osseointegration failure means usually sometime failure, sometime not failure. That means reversible or irreversible. Okay, next one is prosthesis deliver several months later. At this time, there are many checking points. So prosthesis complications starting from the ill contact point, ill occlusion, ill porcelain thickness, ill passive fitness failure. So there are many checking point, contact point, occlusion, prosthesis, cement remnant, and then passive fitness. So this kind of the several complication makes a later time, some make a big complication here. And then if you apply cement retention, sometimes the cement remnant make some the periimplantitis or periimplant mucositis.
This used to be
So
a big deal 10 years ago,
right?
right?
SCRP retention or screw retention, 1 month later checking is not necessary. But cement retention, please check 1 month later.
Used to be biggest
And
reason
then,
why we lose
that
bone.
means cement and plaque induced periimplant mucositis or periimplantitis. Dr. Wassa 73, yes, bone loss around the implant at the time of second stage retter.
So he's just answering because this was
But that is
live
not failure.
through
At
YouTube.
this
So he
time,
was answering some of the questions from
autogenous bone grafting or sometime grinding the rough surface.
the audience
Later,
when he was doing
let's
this
check one by
recording this
one.
live.
And then 6 months later, that means start the prosthetic complication. Sometime screw loosening, sometime, or from the ill-fitting prosthesis make some of the angular bone, vertical bone resorption. And then until 3 years, sometime delayed implant failure, screw fracture, porcelain fracture, food infection. There are too many complications. Of course, these 3 complications can be managed by the retrievability. So this is the big reason why we prefer screw retention or SGRP retention rather than the cement retention. So this is the complication pathway. This is the briefly we have to keep in mind this one. Surgery, suture remover, 4 weeks. This is my protocol. Every my patient follow this follow-up period. And then second surgery, delivery, 1 month, 6 months, 3 years. Until 3 years, no problem. Definitely 10 years, no problem. 10 years, no problem means 20 years, no problem.
Wow.
Nowadays, we talk about 20 years implant longevity guarantee. 20 years. I started the implant in 1995, so maybe 26 years have passed. I started the implant. There
I
are
started
too many
1997.
concept
He's
changes.
2 years ahead of me.
But most important one is the implant length. This topic later I will check more briefly. So 3 years means functional rehabilitation completion period.
That's what he says, Sang-woo. 20
Strategy
years
approach for
guarantee.
implant removal.
That's strong. That's strong.
Today's second topic.
I'll let him do my implant.
As an implantologist, we always concern how to remove an implant. There are too many techniques is available, I know. Sometimes implant mobility, you can take out by your finger. implant mobility increase, you can take out by the forceps. But I want to talk about maybe 200 Newton, 500 Newton, 1000, 1000 Newton. How to remove this one? Before starting this concept, we have to know the expected bone engagement first. This protocol start my big database. Expected bone engagement around the 50 to the 100 Newton. That means you can take out by the torque wrench. It's okay. Please remind, every company torque wrench usually can handle the 100, 200. 200 and more, sometimes broken here. So optimal torque wrench, the gauge is usually 100. So expected bone engagement, 50 to 100 Newton.
Yeah,
you
so
can take
this
out
is
by
what
the
he's
torque wrench first.
well known for.
You are first to try torque wrench.
Systemizing
then
complication. That's
expected
what
bone
Dr.
engagement.
Jeon is well
Why
known for.
I write down expected? That means we don't know. We cannot know the bone engagement, implant and bone binding power. We don't know, right? So I just only say expected bone engagement, 100 to 200 Newton, sometimes 300 Newton. That means sometimes you can use the company kit. Company kit means there are too many company kit. Some the Megagen implant, for example, Megagen 911 kit. Some the dentist implant, the Save kit. The O-stem implant, the EFR kit. So many implant company produce some the special kit, just like for an easy implant remover. But this kind of the company kit also, the maximum range is 300 Newton. Above 300 Newton is impossible, no meaningful.
The kit will break.
Third one is expected bone engagement, maybe 200 to 400 Newton. That means initially you can try the bone guttering. Bone guttering means make a bone remover around the implant first, and then you can try luxation here.
With the 557 drill,
And then sometime
buckle troughing.
company kit, and then you can try take out by the forceps.
It's a combination,
Anyhow, this is the expected bone engagement, 200 to 400 Newton.
which is
And
common
then next,
for me is a mandibular. The maxillary, typically the company kit, like a EFR or the 911 kit works really good. But the mandibular bone, where the implant's been there more than few years, that, in my opinion, ranges from 200 to 400. And a mandibular arch is oftentimes you have to do a buccal troughing, which he calls it a bone guttering. Okay.
one, expected bone engagement above the 400 Newton. Usually screw fracture inside. Of course, as a clinician, we know how to remove the screw, the remnant in the inside of the implant fixture area. But sometimes it's very difficult to remove,
It's very,
or
very
sometimes it's impossible to remove.
It's harder to remove a broken
the
screw
remnant
than
of the
broken
screw.
implant.
That means
I
you
agree
have to
with him.
remove the implant.
Yeah, it's
That
easier to
means
remove the
usually
implant.
around the 400 Newton more. By thread fiber or then sometimes the elevation with the forceps. And then the final one is, this is my technique, the window technique here. The window technique means maybe expected bone engagement above 400 Newton, and then sometimes aesthetic failure, sometimes screw fracture, removal failure. That means it requires bone window. You can ask me, how do you decide expected bone engagement 50, 100, 100, 200, 200, 400, 400 more, around the 400. This is the data here.
So really, the
My
400 is
26
a
years data,
is
I checked the implant bone
make it or
binding
break it,
power
you know.
here. Of course, I have a 400 Newton instrument. I don't have 800 Newton instrument. So, but we can calculate from the 400 Newton. So there are three factors related with the implant and bone binding power. So maybe this is the no bone resorption. Maybe this is the 25%, and then this 50%. This is the 75% bone loss. For example, at this time, this is my data here. This is the 1 year later. First one, implant bone binding power according to the time first. And then next one, surface. And then final one, bone loss. So with these three factors, we can guess.
Okay, wow, this is good. This is good. I never heard anybody talk about in that regard. Oftentimes we talk about implant correlation to how long it's been integrated for. For example, we restore implant after 4 months. All of us do, most of us. But after 4 months, the integration is not that strong. It's clinically acceptable, biologically acceptable. That's why we put the prosthetics on. But the reality is that the actual bone surrounding that implant fixture, the turnover hasn't completely occurred. It takes over a year. So the real significant bone to implant biological osseointegration strength start to become significant in average after about a year. So anything below a year is a lot easier to remove. You don't need a fancy way to remove it. You just grab a torque wrench and reverse it, and 99% of the time it will come out. And what he has done is he basically used his own database, and because he's done 30,000-40,000 implants, right? And he started to measure this implant and finding out in a correlation to the amount of the time that was integrated to the force that's required to reverse it out. And that's one factor. Second is he's talking about the surface. So a lot of companies don't talk about it. Every company says that their implant is best implant surface, but that's not true. So a certain surface, in a given same surface area, because the surface morphology, it will give better binding power. And prime example is Straumann SA surface, which is very well known for and is copied by so many companies like a Megagen, Hyosung is a variation of a dual surface treatment, right? And also, of course, third one, bone loss, right? How much bone has lost. But I think if I were to add one more to this list here, is a location of the mouth. Posterior maxilla versus posterior mandible, even if it's fully integrated, the amount of the force to reverse it in the posterior maxilla is so much easier because of the bone density is less than in the posterior and in the area of posterior maxilla. Okay. Fascinating.
The implant and bone binding power. So from this data, you can select proper techniques for implant remover. For example, if you apply some the SLA sulcus implant, SLA sulcus, and then this SLA surface implant 1
SA
year
surface,
later,
talk about
and
dual
then
surface.
bone resorption maybe 75%, that means bone binding power definitely 100 Newton. 100 Newton means you can use the torque wrenches, okay?
Agree.
The
Yeah.
counterclockwise.
Yeah, for sure.
Same implant area, 2 years later, it increased 150. So how can I calculate this data? Because I want to know the no bone resorption 3 years later, and then SLA sulcus. That means definitely nowadays I know this is the 800 Newton here. 800 Newton binding power. Implant and bone binding power is 800. How can I know this one? Because I have 400 Newton here. So SLA sulcus, and 3 years later, and then bone resorption 50% means the binding power 400 Newton. Because I have an instrument, 400 Newton instrument. So from this data, we can calculate.
Everybody take a screen capture shot. I tell you, take this screen capture shot, man.
No bone loss. That means binding power increases.
Screen capture right now.
This slide is very important because implant bone binding power guess. We can expect the implant bone binding power, and then we can select.
And he even, did what I was mentioning. I didn't see this one before. Soft bone, regular bone, and hard bone. He has a correlation even according to the area of the hardness of the bone. Okay, so this truly is a money shot. Amazing. Yeah.
Proper techniques. Please remind, implant bone binding power relates to 3 factors: time, surface, and then bone loss amount. So with this concept, sometimes you can try the torque wrench. Sometimes you can try bone guttering and then elevation and then take out by the forceps. Sometimes implant company kit. Implant company kit, I know everything. Some of the Megagen implant or dentist, Ostem, Dentium, there are too many kits in the world. But the technically, the application method is a little bit different. The point is just settling to some of the instrument to the implant area. Sometimes clockwise, sometimes counterclockwise. Anyhow, you can run from each company kit. This is no problem. Today, I want to talk about only two techniques, trap fiber and then my window technique. Please remind. Today, firstly, I talk about the complication whole pathway. Each topic require 4 hours lecture, definitely. At the time of the surgery, intraoperative complication, and then suture removal time, and then 4 weeks later. 4 weeks later, sometime if you want to take out the implant, that means implant binding power below.
No, Patrick, if you look at it, soft one, so in a given same situation right here, okay, everything being equal, soft bone requires less power than, where is it? There's a 250, 70, 100. Oh, you're right. The hard bone is higher, but the soft bone, I think he might have got the S and the R mixed up here. Okay, S and the R mixed up. Okay.
That means very easy remover.
Yeah, Patrick, you have a good point.
At the time of the second surgery.
But Patrick, if you look at it, the hard bone is higher though, right? Okay, hard bone is higher, but the regular R, okay, which is lower. So I think those numbers are maybe mixed up.
Time is very important.
But anyway, the point is that we need to take in consideration of the hardness of the bone.
1 year later, 3 years later, 10 years later, if you want take out the implant, at that time you have to think about just the trap fiber or window technique. So anyhow, this implant remover and the complication pathway related to each other very strongly here. So first try premolar forceps, and then fixture driver with a torque wrench. Your second try bone guttering with the fixture bar and the luxation with the tooth elevator. And then third try removal kit, implant company kit. And then your final try trap fiber and window technique. Today I want to talk about this is the 100 Newton until the 200 Newton until 300 Newton, 400 to 800. Hydroxyapatite coating implant. That means usually 1,000 more the binding power.
Did you hear what he said? Probably a lot of you guys are too young to have ever used the HA coated implant. HA coated. When I was in my early career, for all soft bone area, posterior maxilla, we were trained by Carl Misch, who was one of my very first mentors, to specifically use HA coated implant, hydroxyapatite. That significantly increased the bonding strength between the bone and the surface of the implant. Okay, so that's what it's referring to. But the reality is that nowadays no company makes HA coated implant. You notice that? It's hard to find HA coated implant. If the bond strength is that good, why isn't company no longer making HA coated implant? They're notorious for failures. Notorious. Okay, yeah. Once it gets contaminated with bacteria, the amount of the bone that you'll lose is very, very rapid. Okay, so it would have a higher failure rate in a long run. That's why the company start to move away from HA coated. I just wanted to share that with you.
So that means require first try trap fiber or my window technique. Okay, this is some of the gradual the pattern for the expected bone engagement, implant bone binding power here. So today I want to talk about first try trap fiber and the window technique. This trap fiber is very easy to use because the implant outer diameter and the trap fiber inner diameter, the difference only 0.2 millimeter. So you can select the proper one here. So inner diameter, outer diameter, the difference 0.2 millimeter. So 0.2 millimeter means just no friction, just the insertion is very easy. If you want use the thread fiber, please follow this guideline here. If you want remove.
I don't know if I agree with that. Trefine is one of the hardest to use and hardest to teach the young surgeons to use. They chatter like crazy. If you're not careful, if you don't have a steady hand, you can really hurt somebody. You know,
The 4.5 implant, for example, that means this is the thread fiber insertion. Please depends on only cutting power of the thread fiber, not press, please. This pressure is very dangerous sometimes.
yes, yes.
So I want definitely bone cutting by the cutting power only, only the thread fiber. So initially, just the up and down movement, up and down movement here, and then finally, 70% is the optimal, 70%. 70% means 10 millimeter implant remover require 7 millimeter drilling is okay. Usually, the thread fiber has some the length coding the line here, length coding. So and then next one, this is the 7 millimeter drilling here. You can guess the bone binding power. I already recommend. No bone loss means 3 years later, this implant bone binding power 800 Newton, right? And then 50% bone loss.
Marco, you think so? Marco said something. I think the SRH refers to torque slide from SA surface, RBM surface to HS. So you might be right. You might be correct. Okay. Yeah. Then that makes sense. Okay. So he's talking about different surfaces. But HA, nobody uses HA, Marco. So it's kind of you know, not very relevant today. But you know, that could be a possibility.
And then 75% bone loss means 200 Newton. That means this bone binding power changes from the 800 to the 200 Newton here. This is the very important concept. And then next one, at this time you try some the company kit. Or at this time you try some the tooth elevator luxation here. And then next one, luxation try.
If you remove that much bone, company kit will take out this implant really easy, right? You can reverse those out with the EFR kit.
What is the big impact of the thread fiber? I think the thread fiber big impact is immediate correction here. Because this area bone removal here. But this area no bone removal. This area only luxation and then implant removal by the tooth forceps. So this purpose, this impact is means I want immediate implant placement right after implant removal.
Yeah.
So that means this is the apical support only
Yeah.
here. This implant, I take out a 4.5 implant, 10 millimeter implant. That means your next try, immediate correction means, of course, same 10 millimeter implant. How about implant diameter? 5.0? No. 6.0 is okay. 2 step later, diameter is better. So at this time, the next one is same length, and then 6.0 is okay. If you take out a 5.0 10 millimeter implant, for example, that means your next try 7.0 is better. The 2 step later diameter is optimal for initial stability. So that means we have to prepare in your clinic so many highly various the implant diameter. 3.5, 4.0, 4.5, 5.0, 5.5, 6.0, finally 7.0. 7.0 means 5.0 second approach. 6.0 means 4.5. So thread fiber removal, thread fiber means just you holding the foam holding the handpiece and then up and down movement. And then 7 millimeter, 70% of the implant length removed.
Yeah, I think I know what you mean, Sang. I think it depends on what type of implant system it is. Like for example, if we're using MegaGen and ET3 system, you take out a 4.5 by 10 and you try to put a 6.0 by 10, it's virtually impossible because the bottom ends, they're so wide with those systems, it will spin. It will bottom out, right? Okay. So I think Sang, I agree with you. I respect his reasoning, but we do have to take into the context of what kind of macro design of the each individual implant system, right? I think take-home message is that you need enough inventory to be able to replant it. Because if it's a hard bone, if it's a hard bone, the mandibular, oftentimes you can take a 4.5 by 10 out, reverse it out, and put another 4.5 by 10. But in a soft bone, right, it's you will need a wider diameter implant, right? So that part I respect that. Yeah.
This is the how to use optimal use of the thread fiber. So this is the malposition of the implant, and then recurrent the screw loosening. So this is the
External hex.
initially thread fiber, and then up and down movement, up and down.
Yeah.
And then this is the
External hex system, one of the notorious downside is a screw loosening or screw breaking, right?
And then 7 millimeter, 7. This is the length coding here. And the next one, relaxation, take out the implant here. So, and then next one, immediate correction. If this implant diameter 5.0, next one is 7.0 is okay. If this implant 4.5, next implant 6.0 is okay. Of course, sometimes you require the cyclical drilling for the implant positioning. And then next one, 7.0, 10 millimeter is better. Like this one. Okay. But I don't like thread fiber because the thread fiber, that means it requires
He talks about all this now. He says he doesn't like it, right? I love his honesty.
Because the drill just the sharpness the decrease usually, and then the without sharpness, sometimes you at the time of the drilling you press the thread fiber. Sometimes knob damage here. So I don't like the thread fiber. I like this technique, the implant remover by the window technique. I just call this my last name Dr. John. So this is Dr. John's technique.
He developed this
Implant remover
technique. Let's see.
by the window technique is very similar to thread fiber, but the concept is different. The thread fiber and window technique means I want to take out the lateral window of the buccal wall. This is my concept here.
So Sam, that's the punchline, man. He was teasing us with all the thread fine and all this, but actually he doesn't really use that technique. He uses this, whatever this is.
This window buccal wall re-GBL. Definitely after crushing here. So that means just 50% or 70% make some the 2 vertical osteotomy and then 1 basal bone cutting, and then buccal wall take out here. And then that means buccal wall takeout means implant bone binding power 50% decrease. And then guttering means that means 200 Newton decrease. So finally, this implant bone binding power may be 200 Newton. So this window technique,
I don't get it.
I think there are 2 situations available. First one, before during a surgery or after prosthesis. During a surgery, of course, it's very easy to remove, but sometimes a little difficult. So I strongly recommend this kind of the window technique is very, very important here. So let's check briefly first. Just
Okay. So what he's saying is that sometimes certain type of implants are so aggressive that you over torque it and trying to reverse it, but it gets stuck. And if you try to reverse it using a torque wrench, you will cause a deformation of the connection, and it gets very, very difficult. So he's saying that can use this during the surgery to reverse out an implant and then replace with another. That's what I think what he means.
For
Holy
example,
shit, what happened
this
here?
patient referred to me with this state. So maybe the first doctor forgot the change to the mode changes. So this implant may be inserted by the 1,500 RPM here.
Oh.
So like here. How to
Oh,
remove
yeah.
this implant? Of course.
So the doctor forgot to change the setting when delivering the implant. That's what we teach all our resident doctors, right, at the implant course. Built in a mechanics so that this doesn't happen. Always before you use a drill or place an implant, step on a pedal and test the speed before you move into the mouth. Always, every single step of changing the drills, okay? you need to develop that good habit so that you can avoid this.
Now cannot reach the fixed driver inside the implant
That's
top area.
dangerous.
So it requires window making first here. Window making. This window means 2 vertical bone cut and 1 basal bone cut. And then take out the lateral window and then you take out the implant. And then this lateral window re-crushing and then re-GBL is possible here. So at this time, I make a 2 situation here. And then 1 cutting here. And this bone take out. And then implant removal is very easily. And then next one, this is the maybe numbness. We can guess. So first doctor is to worry about this one. So anyhow, what's happening here? So at this time, usually PRF insertion first. Because the PRF sometimes very helpful for the nerve regeneration. Because the PRF has many cytokines. The interleukin 1, interleukin 4, interleukin 6. And then VEGF and then TNF. The VEGF means the vascular endothelial growth factor. So sometimes the PRF insertion first.
So when you say PRF, he's not talking about sticky bone. He's talking about PRF gel itself. Okay, without any bone material whatsoever, just PRF, which is basically a high density blood clot, right? With all the goodies in there.
And next one, the buccal wall crushing, and then GBL here. Over the
He's
PRF.
reusing the
And
bone
then
that the
final
block
one,
of bone that he removed.
the
He's
resorbable
crushing it.
membrane. This
Yeah.
is the very simple, the socket preservation.
Okay, yeah.
And then this patient return the first doctor. Very interestingly, this patient, how about the numbness, this patient? Definitely until 3 months, total numbness here, this patient. But 3 months later, almost 90% recovery.
Oh, nice,
The
impressive.
point is, the fast remover is the key point. Fast remover. Anyhow, this implant, this patient referred to me.
Which is also true. If you have a nerve damage, right? Okay, because of the implant is too close to the nerve, the consensus nowadays is that don't wait till just the numbness go away slowly. The best thing to do is reverse it. Okay, sooner you reverse it, okay, the higher chance of a nerve returning.
And then I make a lateral window of the buccal wall, and then implant remover. And then inside the part, the PRF insertion. The secondarily bone crushing in the GBR, and finally resolve membrane. And then the
Another
first
reason
doctor,
to do
2 more implant,
PRF,
and then
right?
Finishing here.
Yeah.
Very fortunately, almost no numbness nowadays. Anyhow, this is during the surgery, sometimes you can apply the window technique here. I just call, this is the soft marrow bone, empty marrow bone. Can I move the white ball? Dental bay? Can I move it here? Move here?
Oh, he's disappeared.
I always command, please, at the time of
I'm
the
gonna
implant
move my-
surgery, please remind the soft marrow bone. And then
Hope you guys are enjoying this, eh? I know it's a long one tonight, okay? But please tell me that this is worth your time. Okay, how wonderful is this? From somebody with this much of experience, you don't have to agree with everything he say, but you gotta respect, okay, his reasoning and his systematic approach to a complication. You gotta respect that.
just call this is the also empty marrow bone here. What does that mean? Of course, it's very rare, but sometimes you meet here. This is cortical bone is good, but this inside part, no bone here, no empty marrow bone. At this time, you apply the implant here. Implant insertion, at the time 10 Newton here. More deeper, 20 Newton.
And all
More
of a sudden,
deeper,
boom.
30 Newton. But after penetration of the cortical bone, at this time, this implant, 0 Newton here. So at this time, this implant, mobility here. Maybe some implantor have many experience like this one. I just call this situation soft marrow bone or empty marrow bone here. How to remove this implant at this time? Implant inside of the cortical bone. At this time, some doctor try fix a driver insertion and then reverse stock here. This is not effective. This situation means this implant more and more deeper moving to the deep side here.
Like a
If
quicksand.
you find empty marrow bone, every surgery stop, please. And then you make a window here. And then pincel removal is okay, pincel.
I'm going to add something to his say, okay? We've been getting more complication referral recently, implants dropping into the marrow space, okay? I've been witnessing more and more of these, okay, when I'm getting referral. Why is that? Why do we see more of this implant dropping down into the marrow space like what Professor Jeon is talking about compared to we didn't see as many before? You know what? It's a double-edged sword. Zero bone loss concept. This is the thing, okay? This has been double-edged sword. So a lot of dentists now are being taught to place implant deeper than conventionally. How deep? We talk about 4 mm rule, right? 4 mm below the crest of the soft tissue, right? Okay. However, because we're doing that without thinking, just automatically, when we are placing implant, okay, some dentists, okay, they don't look at the bone density in a CBCT Hounsfield value. They don't look into the detail of the eggshell, and then they keep on going. I got another millimeter, and the whole thing drops down. Okay, so there is a danger of just trying to apply one concept, okay, into every surgery, and you can get into that problem.
Good. This area, inside part, empty marrow bone means no bone engaged to the implant. So if you try the fixed driver, that means no bone engages. So more deeper and deeper, moving to the nerve area usually. Please be careful. So this kind of the window technique is also very effective. Just like empty marrow bone space.
That's what I was talking about
So,
during the
that means
complication.
This patient
Okay,
referred
yeah.
to me at this
Intra
time.
complication.
So this doctor also very experienced doctor. Maybe 15 years more. And then anyhow at this time, okay, I start lateral window because this is the empty marrow bone here. And then please check the mental foramen in the nerve area. And then I make a lateral window. And then I take out by the pincet. Pincet, please. Sometimes the mosquito and hemostasis is okay, but not try fixed driver with the counterclockwise. This is the more jeopardize this situation here. So I make a lateral window, and then take out the lateral window, and then pin.
Better device to use is a Nobel implant reversing tool, because Nobel reversing tool, the Christmas tree, you could turn it counterclockwise, and as you turn it counterclockwise, it engages the implant. Okay, and then you get the binding, but not your normal implant driver, torque wrench driver, because that's going to require to fit in there, and that's going to push it further in.
Take out here. And then this area, inside part, PRF. And then this bone crushing, and then resorbable membrane. With this state, this patient returned the first doctor here. There are many cases. This patient referred to me, and then the first doctor tried this implant remover by fixed driver, but this implant more deeper and deeper, moving to the lower part here. And then, so at this time, this patient referred to me. Please not try any action at this time. Make a lateral window first. Two vertical osteotomy and one horizontal osteotomy, and then you take out the lateral window, and then pincel removal is okay. Very fortunately, this implant not make a numbness because no drilling, just your finger insertion means usually touching the nerve, but usually no numbness. So same technique here. This is the make a lateral window.
I mean, this is similar to when a dentist drops the implant into the sinus, right? When those cases come to me, I gotta make a lot of window, and use a with
There are many cases
condylar
referred to me.
forceps
Just
to remove
this
it.
is the empty marrow bone, soft marrow bone, D5 bone or D4 bone. Sometimes you meet. So after
And you get this quite common with the guided surgery cases too, guys. So those of you guys are doing a lot of guided surgery, fully guided surgery. That's why I do not recommend fully guided surgery. Because fully guided surgery for beginner doctors, you don't get the feel for the density of the bone. You just drill like a robot, and the technicians who are planning it, they submerge the implant quite deep, and they don't take into consideration of the softness of the bone, and you end up getting an implant a lot deeper than you've planned. Okay, so
Concentration in cortical bone,
gotta be careful.
implant stability 0 Newton. 0 Newton means we cannot expect the implant the osseointegration. So removal is the only way. At this time, make a lateral window. Bone window is the key point here. So this is the too soft bone. So lateral window take out, and then pin cell remover. At this time, if too far to the inferior nerve, that means you can packing the bone is okay. So before packing the bone, PRF insertion first. If you don't have a PRF, collar tape insertion first. It's okay. And then next one, the lateral window crushing or beta TCP or BCP bone. The synthetic bone is better than the xenograft. And then membrane covering. You can try 4 or 6 months later reinstallation. This is the only way you can control how to control the soft marrow bone or empty marrow bone here. Okay, today final topic is implant remover, the after processes. There are many times.
So what he talked about during the surgery is exactly that. You know, if the implant drops in or implant stuck, need to remove it. So, you know, his concept is to remove the bone where you know you can gain an access and to be able to remove those implants. But the reason he chose the buccal wall is because out of all the surfaces, buccal is the easiest to rebuild. Okay, that's why he's chose the buccal wall, not interproximal or anywhere else.
Of course, I know. This is very annoying to me, But anyhow, we have to remove an implant. Remove. So, implant, no bone loss. Only some other problem. And then we have to take out the implant. That means this implant bone binding power 800 Newton here, definitely. So,
One
that
cell.
means the only way is trap fiber or make a bone window here. So I want to reduce this bone binding power 200 Newton. And then the window technique, the big advantage means no one use the special instrument, just a low speed handpiece and 700 the Fisher bar, and then just the luxation. And then this bone window re-GBL is possible by the crushing. So let's briefly check several cases, and then today I want to finish it here.
Peter, he's talking about just PRF as a gel. PRF as a gel, because once you turn into a flat membrane, you're losing some of the goody stuff. Okay, so I'm almost 100% sure that he's talking about the gel state, not the membrane state.
Patient, this implant referred to me also. So initially I tried some the implant company kit. Like here, flap elevation. Usually, implant remover, flap design, unilateral vertical flap is okay. No necessary usually 2 vertical incision, the wide flap. 1 vertical is sufficient usually. And then at this time, I apply the 1 vertical incision, like this one. And then initially I try some the implant kit. And then, but this implant kit, not effective here. Not effective. Finally, I change it to just make some the window technique here. 2 vertical cutting and 1 horizontal cutting here. And then this bone takeout. Please remind, with this action, implant bone binding power decrease. Quarter portion. So at this time, like here, I take out this bone fragment, lateral window, bone window here. And then this situation, implant bone binding power, 50% decrease. And the next one, guttering. By the Fisher bar here. The guttering here, just like here. And then by the tooth elevator, you try the luxation here. Maybe in total time, 10 minutes.
So I'm going to explain a little bit because I think a lot of you guys probably missed it, okay? So he's combining two technique. One is the term, the coined by Professor Jeon himself is buccal window removal. Basically, you make a 2 vertical, 1 horizontal. It's like a Ramus block. Okay, those of us who used to do a lot of Ramus block, that's what we do, right? Okay, 2 cuts, and then easiest bird to use is a 45-degree oral surgery handpiece with a loss of water. Okay, yeah, you can use 557. 2, 2, and 3, take it out, and that will reduce the overall macro surface area. But that alone is not enough, because you need space to move a tooth, or need a space to move implant in this case. So he does what? Guttering. And that's a term that we're not used to. What he's talking about is troughing. Okay, the pop buccal and interproximal troughing using oral surgery handpiece once again with the 557 burr with a loss of water. Okay, and that will create a space for your 301 elevator or whatever the luxator you want to start luxating. Or if you have an EFR kit or whatever the company kit, you can try to reverse that out at that stage. Yeah.
Below the 10 minutes. And then next one, I should starting this cycle drilling because a little bit lingual placement is better. You know the reason, right? Immediate correction or immediate placement or every situation require lingual side drilling is the first step. Palatal side on the upper jaw.
Dr. Albert Louis covered that at the immediate molar study club at the last session, why it is important to, with almost all the immediate molar cases, need to stay palatally or lingually, right?
On the lingual side, there are 4 regions. Anyhow, immediate correction here. Like this one, and then next one, the GBR, and then the membrane covering. So this implant, initially I tried some of the company kit, but not effective. So I make a lateral window, just a bone window here, like this one, and then reinsertion, immediate correction.
Oh, that was a really good question. I almost forgot to answer. Somebody asked, I wonder if the bone density is any better after such a grafting. Grafting alone, it can improve the graft, because what you're doing is you go into the cancellous compartment, you're creating a blood clot again, right, using a PRF, and as a blood clot, that will cause the cell differentiation into osteoblast cells. You can do that. But what really makes the quality around in the cancellous compartment better is once you place an implant, and as the osseointegration occurs to the surface of the implant, even in those soft bone areas, what you'll see over the years is the cortication happening around that implant. Okay, yeah. So it's not going to change the whole compartment of the empty bone marrow filled with bone. But what I noticed in my years, 25 years, is that the implant, after I place an implant, and when I take an update on X-ray over the years, following them, you actually get a cortication happening around the thread, okay, which is actually very good strong bone.
Next one, I finished the final processes. As you can see, this is the late buccal wall, highly predictable here.
It's like a veneer grafting, right? Buccal veneer grafting. That's what we do. You can use allograft,
without
sticky
PRF,
bone.
Without PRF, resorbable membrane first is better. But I think, I have a 19 numbness patient, 19. But at that time, I think the most important factor is the decompression is the first step. So if you think the definite numbness occur, that means nothing is better, nothing. Because the bone grafting material sometimes damages the pressure to the nerve area. That is some compression. So first point is the decompression is better. Decompression means nothing is better. But if you think some the distance to the inferior nerve, and then if you want to make a bone for the delayed placement, that means PRF and then bone is the first choice.
Yes.
But if you don't have a PRF, the resorbable membrane is good. But this resorbable membrane also, I recommend collar tape is better.
Yes.
You know the
Collar tape or collar plug, something soft. You do not ever want raw allograft bone or cow bone to be in direct contact with infraalveolar nerve. Okay, very good point.
collar tape is the no cross-linking membrane, so resorption rate maybe 2 weeks usually. So the conventional collagen membrane, just like BioGuide or some of the collagen membrane, the cross-linking membrane, not proper. Very soft membrane is better.
Yes.
And then resorbable bone is okay.
What he's talking is
So,
to use a
anyhow,
collagen plug or collagen tape, not
right.
not the
But
actual collagen membrane.
the window technique means the immediate correction also one step later, and then deeper installation is better. Let's organize. Trap-fiber technique means two size bigger and same length is okay, right? But window technique means length increase is better. Length increase. So diameter usually same is better. Same is okay, but length increase. This is a two different situation. Trap-fiber diameter increase. Window technique length increase better. Of course, the remaining available vertical bone is not sufficient. Delayed placement is better. Anyhow, just this is the, let's check. This is unknown implant. And then this implant also, I want to remove this implant here. And then maybe we can guess the binding power. Maybe this implant, the total length is from here to here. This is, I know, this is 800 Newton. And then maybe 25% loss. That means this implant binding power, 600 Newton. 600 Newton is still very high. Not effective. Conventional torque wrench, just the guttering or company kit, not effective. It requires trap-fiber or window technique. But sometimes, this tooth is very, the narrow dimension, trap-fiber insertion is very difficult. At this time, you can try the window technique here. This is the I1 remover by the window technique. So at this time, two implant placement. So this area, I want to design just like a window here, and then bone takeout. And then this means this situation, implant bone binding power 200 Newton. You can guess. And then you can try luxation. And then removal is very easy. Of course, the bone re-GBR by the crushing is possible here. Of course, no problem. Until now, the bone healing and then the labial, the GBR contour is very excellent. There are too many situations I recommend, just like here. And then at this time also, I try. This is the flap design, usually. I want to remove this implant, the later implant, second implant. And then the posterior Y incision, and then one vertical incision. And then, without hesitation, directly I apply two vertical bone cut here. And then, one horizontal bone osteotomy, and then this bone area take out here. Please remind, this means implant bone binding power, quarter, 200 Newton. And the next one, guttering, very slightly guttering, like this one. And then you try luxation here. And then reinstallation immediately. Because the lingual wall usually okay. Lingual wall. So I will try lingual side drilling more and then more deeper installation, deeper. So at this time, this patient, this very fortunately, this is the inferior canal, upper line here. And then this dimension, the safety margin is very sufficient. So this is the finally inferior canal. And then I increase the 1 millimeter more increase here. And then finish here. And this patient returned the first doctor here. Window technique, anyhow. This patient, no bone loss. Repeatedly screw fracture and screw loosening. And finally this patient referred to me.
Did you know that? That implant design was external hex, right? Those of you who are familiar with having a restored external hex, the screw fracturing is notorious. You'll never get implant fracture, but you get screw fracture. So what this case that he's showing, I think it has so many of the repeated screw fracturing. He's decided that it's better to replace the implant.
Just like a two implant remover here. Okay, flap elevation. Usually one vertical incision. This implant remover, trap-fiber, any other technique is very difficult to apply. So at this time, please, this kind
External
of
hex. External hex.
So two vertical bone cut, two implant here, and then one horizontal bone cut here. This bone, finally, I want to use the re-GBR here. And then next one, reach the luxation try.
So
Luxation.
he's saving those bone. He'll probably use a bone crusher to
Radial luxation, distal
moisturize
luxation.
it and then
And then
use a
finally, you
PRF
take out
to
by
make a
the
sticky bone.
premolar tissue fossa. Right
That's
here.
good because you're not wasting the bone. But
Still, maybe
if you
5 or
use an
5, 50
allograft
or
with the
50
PRF,
Newton
I
or
think you'll get
100
pretty
Newton.
similar result.
But
Yeah.
no difficult here. Implant first one remover, second one also one guttering here, and the next one side cut drilling to the lingual side, and then just make a fine implant position and fine implant angulation.
So another reason why he wants to put the new implant a little more lingual or a little more palatal is because that gives you more bigger jump gap. Because remember, okay, he's treating this like an anterior. More buccal jump gap you have, more space to add buccal veneer bone grafting, dual zone, and you have a higher chance of rebuilding that thicker buccal wall. Okay, so that's a little detailed note. I just wanted to share that with you.
And then next one, this is the autogenous bone crushing here. So this bone autogenous bone crushing, and then this bone re-GBR. At the time of the same immediate correction, you have to prepare this kind of the autobone collector or an autobone crusher, and then just like here.
Yeah, there are many different types that you can get.
And this
I have one of
autogenous
those.
bone,
I also have a garlic press,
this is
one that
very
you turn.
simple, very low grade GBR, autogenous bone. And then PRF insertion with a flap closure here. Okay, I finished the surgery. So two implant remover, and then within 10 minutes, usually. When I look back on my previous window technique, not above 10 minutes. And then no require special tools. And then very safe to the nerve area. Just two vertical cut, one horizontal cut. And then more lingual side drilling here. Of course, if you cannot get an initial stability, delayed placement is okay. But superior portion above the inferior nerve is sufficient. Definitely, you can try immediate correction here.
If you have an implant design like a Megagen deep threads or Megagen any ridge, you'll be more than likely be able to place an implant on the same appointment. Okay, because of the side cutting aggressive thread design.
This is the labial, the buccal side wall. Bone is perfect bone configuration here. This is the lingual side and the buccal side. Bone configuration is very good.
Just a veneer grafting.
This technique is also very predictable here. Okay, today my final case. This patient, this is not my implant, but this patient visited with this state. So initially, I cutting this bridge here, and then I place. This is my implant, two implant placement, and then finish the upper jaw here. And then several years later, this implant some mobility. So I try lower 6 implant, 1, 2, 3, 4, 5, 6. 6 implant remover, and then I will try 6 implant here. I start this implant remover. So at this time, okay, flap elevation. This is the suprastructure. Removal is very easy, and then flap elevation here. Each implant, the platform fracture, and then screw fracture here, and then bone resorption maybe 10% or 30%. That means implant bone binding power still very high. So conventional method implant removal is very difficult. Of course, this implant is easy to remove, but another implant is very difficult to remove. So at this time, direct apply.
Those old machine surface implants are the easiest to reverse out. Machine surfaced. HAs are the toughest.
That means this implant bone binding power 200 Newton. And then you take out by the two premolar fossa very easily. And then also same. My point is, as much as possible keep the native bone, and then some the window reuse by the crushing. That is my point. And then immediate correction, definitely. So this kind of some the bone remover, and then retry the luxation here, like this one by one. Just this one is also same. Bone is too hard, maybe D2 bone. So no cancerous bone. That means still, just like trap-fine bird technique is very hard to use. So this window technique is very
This is,
very
I would
versatile.
highly recommend
Very
this
easy
over
to
the
use
Trefine
and very
technique.
easy to apply here. And then I want immediate correction, so the crest are flattening. And then this is the mental frame and finding, and then just a direct measure to the vertical available bone. And then just one by one. Okay, today's topic is only the implant remover. And then
He's using oral surgery handpiece. Oral surgery handpiece with irrigation. It's you know, you can attach it. I have one, but seriously, if you just use an oral surgery high speed with the backflow vent, that one that we often use for thermal extraction, that's just as good. Okay, that's just as good. So the key is not to introduce embolism.
I'm sorry. So I insert the several implant, 6 implant placement. This implant, this immediate loading I try, and then this is the submerging because the big bone defect. So using the 5 implant, I try the immediate loading.
Did you see that? He was using Santal abutment right before there. I don't know if you guys caught that one.
Okay, this is the final processes. So let's check the one by one. So my GBL technique is relatively good. So just the labial plate is good, just like here. This is the final implant. The labial plate is good. The next one is also the good maintenance, the marginal bone. And then the next one is the marginal bone. The GBL result is moderately good. And then this is the much GBL. And then also very stable labial plate. And then like this one, this is the labial plate here. This is labial plate. Sorry, this is the labial plate. Sorry, this is the
other
lingual
way.
one. And then the final one is the same also, just one by one. So this is before, and then this is the removal of the implant, and then immediate correction. So this is immediate loading right after surgery, and then several months later, this is the final result. Okay, the last time for the launching symposium for the Dental Beam Global Webinar. So last time I talked about the full mouth rehabilitation very briefly, just only 1 hour. And then today also I talk about only 1 hour. So the complication pathway, and then some of the special technique for the implant remover. From the next time, every month I will lecture only 2 hours. And then I want your every question, and then I can answer. I'm ready to answer every your question. As I mentioned before, implant complication, 3 factor related each other. Patient problem, and then doctor problem, company problem here. And then if the failure, one more say I want, doesn't kill you, it surely be the driving force. The Friedrich Nietzsche said this one.
If it doesn't kill you, it'll make you stronger.
Nietzsche, I like the great philosopher. So
Nietzsche.
the Friedrich Nietzsche was born in the 1844 maybe. So anyhow, he said, failure be the driving force. And then one more, keep in mind, please. Every failure has its own reason. So from the surgery,
Diagnosis.
1 or 2 weeks later, please check wound opening, wound dehiscence. 4 weeks later, heating necrosis, GBL infection. And then at the time of second surgery, this is the marginal bone resorption, fibrous encapsulation, implant itself problem, and GBL failure. And then prosthetic delivery. There are too many checking points: contact point, occlusion, passive fitness. And
You gotta
then
shoot some heart,
next
man.
one is the
Gotta shoot some
post-prosthetic
heart
period.
and likes.
With this repeated time, you have to check until 3 years. And then 3 years means the functional rehabilitation period. And then we have to know one more thing is, if we want to remove the implant, according to the implant binding power. So expected bone binding power, you remember 800, 400, 200. 3 factors: time, surface, bone resorption amount. Okay, let's call it a day today. So see you next time. I'm really happy to meet by the online webinar with every doctors. Okay, thank you, doctors.
Everybody, give a round of applause, guys. Okay, shoot some heart. Shoot some heart. Shoot some heart. Seriously. That's Professor Jeon. And the reason why I want to do these Gosu series once in a while is because not just because I'm Korean and I'm patriotic to Korea. Okay, that's not the point. In South Korea, these speakers are very in a unique situation, unlike any other. A lot of the academics that, sorry to generalize, that I observe, Europeans, Americans, elsewhere, academics very strong, but they don't do the number of clinically everyday implant surgery and prosthetics. In South Korea, guys like Professor Song, Cho, John, not only they're academic, but they do over 2,000 implants every year at a consistent basis. So they're able to relate the academic and use that fundamental principle and concept to come out with a systematic way to solve everyday clinical problem. That's why they're on my Gosu list. Okay, Gosu. And this is how I learn, right? What Professor Jeon has did, there's some certain things I might not agree 100%, but I do agree with his philosophy and his approach. Okay, you gotta respect that. You gotta respect that. You don't need to be able to do technique, teeth by teeth. You'll develop eventually your own technique, guys. But what the take home is that understand his reasoning, why he's trying to systemize it so that it can make it more predictable and achieve in an efficient way when you have a clinical dilemma such as this here. Okay, there was a lot of pearls tonight. Hope you guys enjoyed it. I certainly did. Okay, and if you like this format of doing a case a reaction, live reaction, give us some reply, give some comments, and see if you enjoy it. I'll do more of these, right? Because I certainly enjoy it, and this is something that I do regularly by myself anyway, so might as well invite you guys to my private coffee show and a private a study club that I do at home. All right, so you guys take care, be safe, I really appreciate all your support for making supporting our institute, and we try to bring as much good content as much as possible, online and also offline as well. All right, so thank you very much, and then I will hope to see you again. Okay, great, excellent.
We had our ups and downs, baby. Sometimes we were tight, and sometimes oceans apart. Gotta learn just how to move on without you. Move on without you. We had our on and offs, baby. Sometimes we were tight, and sometimes everything but. Gotta learn just how to forget about you. Forget about you. Sometimes we were tight, and sometimes oceans apart. Gotta learn just how to move on without you. Move on without you.